The management of gallstone pancreatitis. A question and answer session from fundamentals to advanced clinical scenarios. Welcome to our in-depth podcast episode on the management of gallstone pancreatitis. Today, we will walk through 100 essential questions and answers, covering everything from basic concepts to complex decision-making in clinical practice. Pause the video after each question to attempt answer. Let's begin. Part 1. Fundamentals and Pathophysiology. Question: what is gallstone pancreatitis? Answer: gallstone pancreatitis is an inflammation of the pancreas caused by the obstruction of the pancreatic duct by a gallstone. This blockage results in the premature activation of digestive enzymes within the pancreas, leading to self-digestion of pancreatic tissue. Question: what is the pathophysiological mechanism? Answer: the pathophysiological mechanism involves a gallstone passing from the gallbladder into the common bile duct and becoming lodged at the ampulla of Fada. This obstruction prevents pancreatic enzymes from draining into the duodenum, causing their activation within the pancreatic duct and subsequent inflammation and injury to pancreatic tissue. Question: what are the most common symptoms? Answer: the most common symptoms include severe, constant upper abdominal pain that may radiate to the back, nausea, vomiting, and fever. Question: what are the key laboratory findings? Answer: key laboratory findings are elevated serum amylase and lipase, with lipase being more specific. Liver enzymes such as alanine aminotransferase, aspartate aminotransferase, alkaline phosphatase, and bilirubin are often elevated due to bile duct obstruction. Question: why is lipase more specific than amylase for pancreatitis? Answer: lipase is produced almost exclusively by the pancreas, whereas amylase can also be elevated in conditions involving the salivary glands, kidney disease, and other abdominal issues. Lipase also remains elevated for a longer period. Question: what imaging modality is first line for diagnosis? Answer: contrast-enhanced computed tomography of the abdomen is the first-line imaging modality. It confirms pancreatitis, assesses for necrosis, and detects gallstones. Question: what is the role of ultrasound? Answer: transabdominal ultrasound is the best initial test to confirm the presence of gallstones in the gallbladder and detect a dilated common bile duct. However, it is less reliable for visualizing the pancreas due to overlying bowel gas. Question: what is the Atlanta classification? Answer: the Atlanta classification is a widely accepted system used to classify the severity of acute pancreatitis as mild, moderately severe, or severe, based on the presence of local complications and organ failure. Question: what defines severe acute pancreatitis? Answer: severe acute pancreatitis is defined by the presence of persistent organ failure lasting more than 48 hours, affecting the respiratory, cardiovascular, and/or renal systems. Question: what are some common local complications? Answer: common local complications include acute peripancreatic fluid collections, pancreatic pseudocysts that develop after 4 weeks, and acute necrotic collections that can become walled-off necrosis. Part 2. Initial management and resuscitation. Question: what is the cornerstone of initial management? Answer: the cornerstone of initial management is aggressive intravenous fluid resuscitation. Question: why is fluid resuscitation so critical? Answer: fluid resuscitation is critical because pancreatitis triggers a severe inflammatory response, resulting in fluid loss into tissues, intravascular depletion, shock, and reduced blood flow to the pancreas, which worsens necrosis. Question: what type of fluid is typically used? Answer: lactated Ringer's solution is often preferred over normal saline, as some studies suggest it may reduce systemic inflammation. Question: what is the goal of fluid resuscitation? Answer: the goal of fluid resuscitation is to restore hemodynamic stability and maintain adequate urine output, typically greater than 0.5 milliliters per kilogram per hour. Question: how is severe pain managed? Answer: severe pain is managed with intravenous analgesics, often using patient-controlled analgesia with opioids such as morphine or fentanyl. Nonsteroidal anti-inflammatory drugs are usually avoided due to kidney risk. Question: should a patient be kept nil pros? Answer: yes, initially. Bowel rest helps to reduce pancreatic stimulation and enzyme secretion. Question: when can enteral nutrition be started? Answer: in severe or predicted severe pancreatitis, enteral nutrition via a nasojejunal or nasogastric tube should be started early, within 24 to 72 hours. To maintain gut barrier function and prevent bacterial translocation. Question. Why is enteral nutrition preferred over total parenteral nutrition? Answer. Enteral nutrition is preferred because it is associated with fewer infectious complications, is less expensive, and helps preserve the intestinal mucosal barrier. Question. What is the role of prophylactic antibiotics? Answer. Prophylactic antibiotics are not routinely recommended. They should be used only for proven or suspected extrapancreatic infection or for infected pancreatic necrosis. Question. How is disease severity predicted? Answer. Disease severity is predicted using scoring systems such as the bedside index for severity in acute pancreatitis, Ranson's criteria, or the acute physiology and chronic health evaluation 2, and by monitoring for organ failure. Part 3. Diagnostic and interventional approach. Question. What is the role of magnetic resonance cholangiopancreatography? Answer. Magnetic resonance cholangiopancreatography provides a non-invasive way to visualize the biliary and pancreatic ducts, aiding in the detection of retained common bile duct stones, ductal anatomy, and complications such as pseudocysts. Question. When is endoscopic ultrasound used? Answer. Endoscopic ultrasound is highly sensitive for detecting small common bile duct stones or sludge, especially when other imaging is inconclusive. It can also be used for tissue sampling. Question. What is the definitive procedure for removing a stone from the common bile duct? Answer. Endoscopic retrograde cholangiopancreatography with sphincterotomy and stone extraction is the definitive procedure. Question. When is endoscopic retrograde cholangiopancreatography indicated in gallstone pancreatitis? Answer. Endoscopic retrograde cholangiopancreatography is indicated emergently, within 24 hours, if there is concurrent acute cholangitis, or if there is persistent biliary obstruction despite conservative management. Question. Is endoscopic retrograde cholangiopancreatography routinely needed in all cases? Answer. No. In most mild cases, the offending stone passes spontaneously and the procedure is not required. Question. What are the risks of endoscopic retrograde cholangiopancreatography? Answer. Risks include pancreatitis, bleeding, perforation, and infection. Question. What is the role of blood cultures? Answer. Blood cultures should be obtained if the patient is febrile or septic to guide antibiotic therapy if a source of infection is identified. Question. How is infected pancreatic necrosis diagnosed? Answer. Infected pancreatic necrosis is diagnosed by combining clinical signs such as persistent fever, increased white blood cell count, and clinical deterioration with confirmation via image-guided fine needle aspiration for culture and gram stain. Question. What is the step-up approach for managing infected necrosis? Answer. The step-up approach starts with antibiotics and percutaneous drainage, followed by minimally invasive necrosectomy if necessary, reserving open surgery for the last resort. Question. What is the significance of a sentinel acute pancreatitis event? Answer. A sentinel acute pancreatitis event is a hypothesis suggesting that the first episode of acute pancreatitis initiates an inflammatory process which can lead to recurrent attacks and potentially chronic pancreatitis in some individuals. Part 4. Surgical management. Cholecystectomy. Question. What is the definitive prevention for recurrent gallstone pancreatitis? Answer. Cholecystectomy, which is the surgical removal of the gallbladder, is the definitive prevention. Question. When should a cholecystectomy be performed for mild gallstone pancreatitis? Answer. Cholecystectomy should be performed during the same admission, once the patient's abdominal pain has resolved and enzyme levels are trending downward, often within 48 to 72 hours. Question. Why is same admission cholecystectomy recommended? Answer. Same admission cholecystectomy significantly reduces the risk of recurrent gallstone-related complications, which can be as high as 25 to 30% within the first few months if the gallbladder is left in place. Question. What if the patient has moderate or severe pancreatitis? Answer. In moderate or severe pancreatitis, cholecystectomy should be delayed until the acute inflammatory process has resolved, fluid collections have stabilized or been drained, and the patient is clinically improving. This delay may be several weeks. Question. What is the preferred surgical approach for cholecystectomy? Answer. Laparoscopic cholecystectomy is considered the gold standard for surgical removal of the gallbladder. Question. What is an intraoperative cholangiogram? Answer. An intraoperative cholangiogram is a procedure where dye is injected into the biliary tree during cholecystectomy to visualize anatomy and identify any retained common bile duct stones. Question: what if a patient is too frail for surgery? Answer: if a patient is too frail for surgery, endoscopic sphincterotomy alone can be considered to reduce the risk of recurrence, though it is less effective than cholecystectomy. Question: what is post-cholecystectomy syndrome? Answer: post-cholecystectomy syndrome refers to the persistence or recurrence of biliary-like symptoms after gallbladder removal, which can be caused by a retained stone, sphincter Avati dysfunction, or other non-biliary issues. Question: can cholecystectomy be performed in pregnancy? Answer: yes. Cholecystectomy can be performed in pregnancy, preferably during the second trimester, as the risk of recurrent pancreatitis poses a greater threat to both mother and fetus than the surgery itself. Question: what if a common bile duct stone is discovered during laparoscopic cholecystectomy? Answer: the surgeon can attempt a laparoscopic common bile duct exploration or refer the patient for postoperative endoscopic retrograde cholangiopancreatography. Part 5. Management of complications. Question: what is a pancreatic pseudocyst? Answer: a pancreatic pseudocyst is a collection of pancreatic fluid enclosed by a well-defined wall of fibrous or granulation tissue, which develops over 4 or more weeks after an episode of acute pancreatitis. Question: how is a symptomatic pseudocyst managed? Answer: asymptomatic pseudocyst may be managed by drainage, which can be performed endoscopically, percutaneously with imaging guidance, or surgically. Question: what is the difference between interstitial edematous pancreatitis and necrotizing pancreatitis? Answer: interstitial edematous pancreatitis involves inflammation and swelling without tissue death, whereas necrotizing pancreatitis involves death of pancreatic and/or peripancreatic tissues. Question: how is sterile necrosis managed? Answer: sterile necrosis is managed conservatively with maximal medical support. Intervention is avoided unless infection is suspected or the patient deteriorates. Question: how is infected necrosis managed? Answer: infected necrosis is managed with antibiotics and drainage or debridement using the step-up approach. Question: what is abdominal compartment syndrome? Answer: abdominal compartment syndrome is a dangerous rise in intra-abdominal pressure that compromises organ blood flow. It can result from severe pancreatitis due to massive fluid resuscitation and visceral swelling. Question: how is abdominal compartment syndrome managed? Answer: management includes medical measures such as fluid restriction and diuresis, with surgical decompressive laparotomy if severe. Question: what is the most common cause of death in the early phase of severe pancreatitis? Answer: persistent organ failure, often resulting from systemic inflammatory response syndrome leading to shock and respiratory failure, is the most common cause of death in the early phase. Question: what is the most common cause of death in the late phase? Answer: infection of pancreatic necrosis is the most common cause of death in the late phase, which is defined as more than 2 weeks after onset. Question: what is the role of a multidisciplinary team? Answer: a multidisciplinary team is crucial for managing complex cases, involving specialists such as gastroenterologists, interventional radiologists, pancreatic surgeons, and critical care physicians. Part 6. Special considerations and scenarios. Question: how is gallstone pancreatitis managed in a pregnant patient? Answer: management is similar to that in non-pregnant patients, with special attention to fetal well-being. Magnetic resonance cholangiopancreatography without gadolinium is safe, and endoscopic retrograde cholangiopancreatography can be performed with fetal shielding. Cholecystectomy is preferred in the second trimester. Question: what is the difference between gallstone pancreatitis and alcoholic pancreatitis? Answer: gallstone pancreatitis results from biliary obstruction, while alcoholic pancreatitis is a toxic metabolic injury from alcohol. Patient history, liver enzyme patterns, and imaging help differentiate the causes. Question: can a patient have both gallstones and alcohol as etiologies? Answer: yes, a patient can have both gallstones and alcohol as causes, and it can be challenging to determine the primary factor. Initial management remains the same, but cholecystectomy is indicated if gallstones are present. Question: what is idiopathic pancreatitis? Answer: idiopathic pancreatitis refers to acute pancreatitis with no identifiable cause after the initial evaluation. Many cases are later found to be due to microlithiasis or biliary crystals. Question: how is idiopathic recurrent pancreatitis investigated? Answer: investigation includes endoscopic ultrasound and/or magnetic resonance cholangiopancreatography to look for structural causes, microlithiasis, pancreativism, tumors, or sphincter of Oddi dysfunction. Question: what is sphincter of Oddi dysfunction? Answer: sphincter of Oddi dysfunction is a benign, non-calculous obstruction to flow at the sphincter of Oddi, which can cause recurrent pancreatitis. It is diagnosed by manometry and treated with sphincterotomy. Question: what is the role of ursodeoxycholic acid? Answer: ursodeoxycholic acid is used to dissolve cholesterol gallstones in patients who are not candidates for surgery. However, its effect is slow, ineffective for large stones, and stones often recur after discontinuation. It has no role in the acute management of pancreatitis. Question: can statins prevent gallstone pancreatitis? Answer: some studies suggest that statins may have a protective effect against gallstone formation and pancreatitis, but they are not a standard preventive measure. Question: what dietary advice is given after recovery? Answer: a low-fat diet is often recommended initially. However, evidence for its long-term necessity after cholecystectomy is weak. It is important to reintroduce food gradually and healthily. Question: what is the long-term risk of developing diabetes after pancreatitis? Answer: significant pancreatic necrosis can damage insulin-producing beta cells, increasing the risk of developing diabetes mellitus, specifically type 3C Part 7. Advanced and nuanced questions. Question: what is the golden window for endoscopic retrograde cholangiopancreatography in acute cholangitis? Answer: the golden window is within 24 hours of diagnosis, as delay is associated with increased mortality. Question: what is the significance of a wall-off in walled-off necrosis? Answer: a wall-off signifies a mature, encapsulated collection that is more amenable to endoscopic or surgical drainage compared to an early, ill-defined acute necrotic collection. Question: what is the role of pancreatic enzyme supplements? Answer: pancreatic enzyme supplements are used in patients with pancreatic exocrine insufficiency, which can develop after severe necrotizing pancreatitis, leading to fatty stools and malabsorption. Question: how is exocrine pancreatic insufficiency diagnosed? Answer: diagnosis is based on a clinical history of fatty stools and confirmed by a fecal elastase test. Question: what is the Atlanta classification revised in 2012? Answer: the revised Atlanta classification in 2012 provides standardized definitions for the types and phases of acute pancreatitis and its local complications, improving communication and research. Question: what is the bedside index for severity in acute pancreatitis score? Answer: the bedside index for severity in acute pancreatitis is a 5-point scoring system based on blood urea nitrogen, impaired mental status, systemic inflammatory response syndrome, age over 60, and pleural effusion, used within the first 24 hours to predict mortality. Question: what is the role of C-reactive protein? Answer: C-reactive protein is a widely used marker to monitor the severity and progression of pancreatitis, with levels greater than 150 mg per liter at 48 hours suggesting severe disease. Question: what is the difference between early and late phases of severe pancreatitis? Answer: the early phase, during the first 1 to 2 weeks, is characterized by systemic inflammatory response syndrome and organ failure. The late phase, after 2 weeks, is characterized by the sequelae of necrosis and local complications. Question: what is the role of therapeutic anticoagulation? Answer: therapeutic anticoagulation is generally contraindicated in the acute phase due to the high risk of bleeding, especially if pseudoaneurysms form. It is used only for a definite separate indication, such as deep vein thrombosis or pulmonary embolism, with extreme caution. Question: can gallstone pancreatitis lead to chronic pancreatitis? Answer: yes, particularly after repeated episodes or a single severe necrotizing episode. Part 8. Rapid-fire fact-based questions. Question: what is the most common cause of acute pancreatitis worldwide? Answer: gallstones are the most common cause of acute pancreatitis worldwide. Question: what percentage of gallstone carriers will develop pancreatitis? Answer: only a small minority, about 3 to 7%, of gallstone carriers will develop pancreatitis. Question: which liver enzyme is most predictive of a gallstone etiology? Answer: Alanine aminotransferase greater than 150 units per liter has a high positive predictive value for gallstone etiology. Question: what is the mortality rate for mild interstitial pancreatitis? Answer: the mortality rate for mild interstitial pancreatitis is less than 1%. Question: what is the mortality rate for infected pancreatic necrosis? Answer: the mortality rate for infected pancreatic necrosis can be as high as 15 to 30%, even with modern management. Question: what organism is most commonly found in infected necrosis? Answer: gut-derived organisms such as Escherichia coli, Klebsiella, and Enterococcus are most commonly found in infected necrosis. Question: what is the most common organ system to fail in severe pancreatitis? Answer: the respiratory system is the most common organ system to fail, often manifesting as acute respiratory distress syndrome. Question: what is the most common vascular complication? Answer: the most common vascular complication is splenic vein thrombosis, which can lead to gastric varices. Question: what is a pseudoaneurysm? Answer: a pseudoaneurysm is a pulsatile hematoma caused by enzymatic erosion of an arterial wall near the pancreas, often the splenic artery, and is a life-threatening cause of hemorrhage. Question: how is a bleeding pseudoaneurysm managed? Answer: urgent angiography with coil embolization is the treatment of choice for a bleeding pseudoaneurysm. Question: what is the colon cutoff sign on an abdominal X-ray? Answer: the colon cutoff sign refers to the absence of colonic gas beyond the splenic flexure due to local inflammation from pancreatitis. Question: what is sentinel loop on X-ray? Answer: sentinel loop is a localized ileus of a small bowel loop in the upper abdomen, seen on X-ray as a sign of localized inflammation from pancreatitis. Question: is nasogastric tube suction necessary? Answer: nasogastric tube suction is not routinely required unless the patient has intractable vomiting or gastric outlet obstruction. Question: what is the role of probiotics in pancreatitis? Answer: probiotics are not recommended, as some studies have shown an increased risk of bowel ischemia and mortality. Question: what is the most critical factor in determining prognosis? Answer: the presence and duration of organ failure is the most critical factor in determining prognosis. Question: what is the recurrence rate of pancreatitis if cholecystectomy is not performed? Answer: the recurrence rate can be up to 25 to 30% within the first few months. Question: can a very small gallstone cause pancreatitis? Answer: yes. Small stones less than 5 mm are actually more likely to pass and cause obstruction at the ampulla. Question: what is the role of computed tomography severity index? Answer: the computed tomography severity index is a scoring system based on contrast-enhanced computed tomography findings that grades the extent of inflammation and necrosis, correlating with morbidity and mortality. Question: what is the most sensitive initial imaging test for detecting gallstones? Answer: transabdominal ultrasound is the most sensitive initial imaging test for detecting gallstones. Question: what is the most sensitive test for detecting common bile duct stones? Answer: endoscopic ultrasound or magnetic resonance cholangiopancreatography are highly sensitive, with endoscopic ultrasound being slightly superior. Part 9. Clinical vignettes and decision-making. Question: a 55-year-old female presents with severe epigastric pain, nausea, and an elevated lipase level. Ultrasound shows gallstones and her alanine aminotransferase is 45. How do you manage her? Answer: this is mild gallstone pancreatitis. Management includes intravenous fluids, analgesia, bowel rest, and planning for a laparoscopic cholecystectomy during the same admission once she is improving. Question: the same patient develops fever, rapid heart rate, and worsening abdominal distension on day 3. What is the next step? Answer: a complication such as infected necrosis or a worsening collection should be suspected. An urgent contrast-enhanced computed tomography of the abdomen should be obtained, blood cultures checked, and broad-spectrum antibiotics started if infection is suspected. Question: a 70-year-old male with severe pancreatitis and necrosis on imaging is not improving after 10 days and develops a fever. What should you do? Answer: infected necrosis should be suspected. Broad-spectrum antibiotics should be started and a computed tomography-guided fine needle aspiration of the necrosis performed for culture confirmation. Question: a patient undergoes endoscopic retrograde cholangiopancreatography for cholangitis and pancreatitis, and 6 hours later their abdominal pain worsens. What is the most likely cause? Answer: The most likely cause is post-endoscopic retrograde cholangiopancreatography pancreatitis, which should be managed supportively with fluids and analgesia. Question. A patient with resolved mild gallstone pancreatitis is scheduled for cholecystectomy but has a recent coronary stent and is on dual antiplatelet therapy. What is the best course? Answer. This is a high-risk scenario requiring multidisciplinary discussion. Options include delaying surgery until antiplatelet therapy can be safely held or performing endoscopic sphincterotomy as a bridge to later cholecystectomy. Question. On a follow-up computed tomography for severe pancreatitis, a 5 cm pseudocyst is found, but the patient is asymptomatic. What is the management? Answer. No intervention is needed for an asymptomatic pseudocyst, as many resolve spontaneously. Question. The same patient with the pseudocyst presents with post-meal pain, vomiting, and early satiety. What is the management? Answer. The pseudocyst is now symptomatic and likely causing gastric outlet obstruction. Endoscopic or percutaneous drainage is indicated. Question. A patient with a history of cholecystectomy for gallstone pancreatitis presents 1 year later with similar pain and elevated lipase. What is the likely cause? Answer. Possible causes include a retained or common bile duct stone, sphincter of Oddi dysfunction, or a new etiology such as alcohol use or high triglycerides. Further investigation with magnetic resonance cholangiopancreatography or endoscopic ultrasound is warranted. Question. A patient in the intensive care unit with severe pancreatitis becomes anuric and hypotensive despite fluid resuscitation. What is the next step? Answer. Persistent organ failure involving the kidneys and cardiovascular system is present. Continuous renal replacement therapy and vasopressor support should be considered, along with assessment for abdominal compartment syndrome. Question. What is the single most important takeaway in managing gallstone pancreatitis? Answer. Initial aggressive supportive care is vital for survival, but definitive therapy with cholecystectomy, or sphincterotomy in select cases, is essential to prevent recurrence. Thank you for joining us for this comprehensive Q&A session on gallstone pancreatitis. We hope this podcast provides clarity and practical guidance for healthcare professionals and anyone interested in understanding this important clinical condition. It's the Everything Surgery Podcast. Dissect the extraordinary.